Hello, everyone. Welcome to today's session, which is addressing living kidney donation and the assessment process for kidney donors. Thank you very much for joining us. We have a great session and great speakers today. Our first presenter will be Dr. Sunita Singh, who is Medical Director of the Living Kidney Donation Program at the Ajmera Transplant Center. And we're also joined by Jane Garrett, who is a living kidney donor and will be sharing her story. As usual, we invite you to submit your questions. To do so, go to slido.com and enter the event code kidney donor. That's slido.com and the event code is kidney donor. So I will now ask Dr. Sunita Singh to review the living kidney donation assessment process. Dr. Singh?
Thanks, Paula, for the introduction, and hi to everybody joining us. Thanks for being part of this session. I'm going to be speaking today. I've titled my talk, Living Kidney Donation, Why, Who, and How. And really what I hope that I can cover for all of you today is to achieve three major objectives. The first is to review briefly some of the treatment options for patients who are living with kidney failure. The other thing I'd like to do is to touch upon, of course, the living kidney donor evaluation process, specifically at our hospital here, and also to touch on the eligibility criteria for people who wish to become living kidney donors. So first and foremost, let's talk a little bit about treatment options for kidney failure. Many of you watching already probably know this, but chronic kidney disease is a pretty common medical problem for many Canadians. 1 in 10 Canadians, so that's almost 4 million people, have chronic kidney disease. And amongst those, about 50,000 Canadians currently are living with kidney failure. There are numerous different causes for kidney failure, but diabetes is by far the most common cause, usually accounting for about 30% or more of kidney failure in Canadians. When thinking about treatment options for those living with kidney failure, the two most commonly discussed are kidney transplantation and dialysis. Now, when we talk about treatment options, kidney transplantation is often, for most individuals, considered the best treatment option for kidney failure. And we've known this for actually quite some time. So what you can see on this graph is effectively a chart that looked at patients who received a kidney transplant and compared their survival, their life expectancy, to patients who are living on chronic dialysis therapy. And the transplant patients are really represented by this black bar here, and the dashed line represents patients with chronic kidney disease. And what you can see is that over time, those who got a transplant are at slightly higher risk of dying in the early period after the procedure, but over time, in weeks, months, or years after the procedure, you can see that life expectancy is better for those with a kidney transplant as compared to those who stay on chronic dialysis therapy. And in addition to the increased life expectancy that I've just touched on, there's obviously an improved quality of life for most individuals. That means being free from dialysis treatments, having a little bit more dietary freedom for most individuals with a transplant as compared to being on dialysis. For many people who wish to travel is far easier for those with a functioning kidney transplant as compared to dialysis. And for those who wish to become pregnant, although people can become pregnant on dialysis, there are numerous advantages to doing so with a functioning kidney transplant. And of course, finally, also the advantages in terms of transplant versus dialysis therapy. For many, it's far easier to return to the workforce with a functioning kidney transplant. Now, in terms of the type of transplants you can receive, there are two options. You can get a kidney from a deceased donor or a kidney from a living donor. And what this chart here shows you is the proportion of transplants that we do here at our institution from deceased donors versus living donors. So it's about 50-50, where 50% of individuals will receive a kidney from someone who has passed away, whose family has decided to proceed with organ donation, and the other 50% approximately will receive a kidney from a living donor. And a living donor can be anybody. It can be a family member, a sibling, a parent, or a child. It can be a friend, a colleague. It can be a complete stranger. So anyone really can be a living kidney donor. There are really no restrictions in terms of relationship to the recipient. If we were to select the advantages between living donation versus deceased donor, deceased donor kidney transplant, we will often say for most individuals that living kidney donor transplants are the preferred therapy for kidney failure as compared to deceased donor transplantation. Why is that? The first is that living kidney donation offers a recipient the best chance for long-term dialysis-free survival. So what does that mean? That means that the probability of being alive with a kidney that is working is better for someone who gets a kidney from a living donor versus someone who gets a kidney from a deceased donor. The median length of time that a kidney works from a living donor is about 18 to 20 years in our program, whereas the median length of time that a kidney works from a deceased donor in our program is about 14 to 15 years. So there's a clear difference there in terms of what we call dialysis-free graft survival. There's also the advantage of being able to spend no time or less time on dialysis. And so for individuals who identify living kidney donors who are on dialysis, they can often come off dialysis and get their transplant, thereby kind of bypassing the long waiting time for a deceased donor transplant. And for those individuals who identify a living donor before dialysis is even needed, they may not need to spend any time on dialysis. And that's what we call a preemptive living donor kidney transplant. For those who get a transplant from a living donor, often the hospital stays are shorter, and there's often lower rates of delayed graft function, which is a condition where the kidney does not work right away. And finally, the surgery can often, and most of the time, be scheduled electively for living donor kidney transplantation as compared to deceased donor transplantation, which can happen day or night at any point in time. Now, touching on what I spoke about just briefly on the last slide about graft survival. So this is a chart that compares graft survival for people who got a kidney from a living donor, represented in the red bars, versus people who got a kidney from a deceased donor, represented in the blue bars, over time after transplant. So this is the probability over time of being alive with a kidney transplant that is working. So you can see in the early months to years after transplantation, there are similar and excellent rates of graft survival. But the probability of being alive with a graft or kidney that is working seems to fall off a little bit over time. And you can see that there's a clear advantage, especially over the long term, for someone who got a kidney from a living donor versus from someone who got a kidney from a deceased donor. So there are advantages in terms of graft survival for living donor transplant recipients versus deceased donor transplant recipients. The other advantage is that living donors really help us tackle the issue of supply versus demand of kidneys. You can see here that over time, although our rates of deceased donors has gone up over time, so from 2006 to 2015, the number of deceased donors has increased from 460 to 650. That doesn't really catch up though to the huge demand that we have for kidneys. So you can see this is a little bit of outdated data, but in 2015, we had over 3,000 people on a waiting list waiting for a kidney. So although the rates of deceased donation have increased, they can't keep up to the huge demand that we have for kidneys. And that demand goes up over time, as we know that the number of people with kidney failure is going up over time. So one of the ways that the organ demand versus supply issue can be tackled is through living kidney donation. So every time somebody donates a kidney, what happens is that's beneficial to everybody living with kidney failure who's on the waiting list, because the number of people on the deceased donor waiting list decreases for every living donor transplant that happens. One person is removed from that list. And as a result, the pool of kidneys available for people on that waiting list who do not have a living donor goes up. And as a result, the waiting time for a transplant goes down collectively for the entire group. So it's really beneficial, not just for an individual receiving the transplant, but for the population of people living with kidney failure as a whole. At the level of the healthcare system, a living donor transplant decreases the time on dialysis for the recipient, decreases the length of stay in hospital, and also increases the years that the kidney transplant works. So overall, that results in numerous healthcare savings to the system that can be utilized for other healthcare needs. So overall beneficial both at an individual level and at a population level. So we know that, I hope that in the past few slides I've been able to show you why we recommend living donor kidney transplantation as the preferred treatment for kidney failure. What about living kidney donors? How are they assessed? And that's really the purpose of today's talk. So living kidney donation has been actually around for a long time. In fact, the first living kidney donor transplant took place in Boston in 1954 on December 23rd. And Dr. Joseph Murray and Dr. John Merrill here were the pioneers of that procedure. And what you can see here on the left side of the slide are Richard and Ronald Herrick. Ronald and Richard were identical twins. Richard was a recipient of Ronald's kidney. Richard had kidney failure from glomerulonephritis, and Ronald was healthy and well and identical genetically to Richard, and he donated his kidney to Richard. And so that was the first kidney transplant, living donor kidney transplant that was performed. And since then, we've done numerous. We are here at UHN, the largest living donor program in Canada. And here I've got a slide here depicting the activity of our program over time from 2006 onwards, although we certainly have been in operation for longer than that. But you can see that over the past 15 years or so, we've done anywhere between 50 and 80-ish living donor kidney transplants per year. So we are a high volume center for living donor kidney transplants. And as I mentioned before, this really accounts for about 50% of our transplant activity here at our institution. Now, some of the principles when we think about living kidney donation. Well, we first strongly believe in our program and programs across the country is that living kidney donors undergo a rigorous evaluation and selection process because the safety of the donor is paramount. So our donors are incredible individuals that are really coming forward to help someone in need. So we are committed to ensuring the safety of that individual. And the whole objective of this evaluation process is to collect as much information as we can about that particular individual that wishes to donate, so we can really estimate or kind of come up with an individualized assessment of risk. So what we want to do is select people who are at low risk when it comes to kidney donation. So for example, if during the evaluation process we identify an individual who themselves have a kidney issue, they would be potentially at risk of getting kidney failure themselves. So those are individuals that we do not want to select for kidney donation. We're looking at risk both in the short term for the procedure itself, but also long-term risk, the risk of getting into problems with their own kidneys or health, general health down the line. The other important principle is that donation has to be voluntary and altruistic. So what's important here is that donors are coming forward out of their own free will, and they're not being pressured or coerced to do so by other individuals. And that's really an important principle. And we do spend a lot of time in our program ensuring that that condition is met. In terms of the evaluation process for a donor, what most people are surprised to know is that not every donor who comes forward goes on to become a donor. For every 5 living kidney donor candidates, so for every 5 candidates or people who are interested in donating, only 1 person goes on to become a kidney donor. And often people may come forward and have no known medical issues, but it's not unusual for us to sometimes identify medical issues during the evaluation process. And as a result, sometimes if that happens, more than 1 donor may need to be evaluated in order to find a suitable donor for that recipient. So we sometimes need to evaluate more than 1 donor for someone before we identify somebody who is suitable to donate. Now, in terms of the evaluation process, this is really a schema of how we evaluate donors in our program, and I'll just walk you through this. The first step is actually that an individual has to present themselves to our program expressing interest by filling out a questionnaire. So this is a health questionnaire that asks numerous questions about their health. And what we would do is review that questionnaire to determine whether or not there's any issues that would prevent someone from moving forward. Now, sometimes based on that questionnaire, we do require additional information. So for example, if somebody comes forward saying that they've had a previous history of breast cancer, we sometimes, not all breast cancers are the same, so we sometimes do need to review a little bit more additional information to determine whether or not it's okay for that individual to proceed with the evaluation. But once the questionnaire has been reviewed, then we can go on to the next phase of testing. I also want to point out that coming forward as a kidney donor does not require a referral from a family physician. Individuals can self-refer and express their own interest. That does not need to be done via a family doctor's office. So if somebody is deemed suitable to proceed with the evaluation process based on their questionnaire, then we go on to laboratory testing. So this is a number of blood and urine tests that we look for to assess general health, but also to specifically evaluate kidney function. So we're looking to see how good is the kidney function and is it enough to permit donation to take place. We often will start this laboratory testing once the recipient who the donor wishes to donate to has been identified, and also had preliminary investigations done by our transplant center. And that's just to really make sure that the donor and the recipient evaluations are aligned and proceeding at the same time. If the laboratory testing, both the blood and urine testing, is acceptable, then we would move on to phase 2, which is the stage of the evaluation where imaging is done. So that includes a chest x-ray and a CT scan of the abdomen, a consultation with our social workers, again, to identify the altruistic and the voluntary nature of the donation, and to really help support our donors through the process in terms of financial coverage, et cetera, as needed, as well as cardiac testing for selected individuals. So we do perform cardiac testing for women over the age of 60 and men over the age of 50. And that's part of the phase 2 part of the evaluation. There's also a teaching session here with our coordinators that is part of the phase 2 evaluation process. Just note at the bottom here, this red box, is that along the way, we might find things that makes individuals unsuitable to donate. So a common scenario is sometimes laboratory testing is performed and we discover that an individual actually has type 2 diabetes. In those cases, type 2 diabetes does prevent an individual to proceed, so people can become unsuitable at any point in time during the evaluation process. After phase 2 is complete, numerous other steps are then taken to complete the evaluation process. I mentioned the coordinator teaching, which is an education session. We also send blood from the donor and the recipient to the histocompatibility lab. And this is to do something called a cross match to determine if the donor and the recipient are compatible, both at the level of the blood group and also the level of the tissue. And I'll get into that in a little bit more detail later in the talk. And then finally, after all of that is complete, a nephrologist will assess the potential candidate and determine if the individual is suitable to donate. Sometimes at that assessment, the donor is found to be unsuitable, and in some cases, additional testing is required before a decision can be made. But that is the general process at our center for the evaluation of a potential candidate. Now, in terms of those who go on to donate, what are the outcomes of our kidney donors? We know that living kidney donation is safe. We've performed thousands of kidney donations here at our hospital, and it's safe because we go through a rigorous living donor selection process. So the evaluation, although has numerous steps in it, it's really to ensure that people who are going through the procedure are safe to do so. People can live normal, healthy lives with one kidney. That is very well known. And the kidney that remains in the body after donation has occurred actually increases in size and compensates to some degree for the one that is missing. It can't completely compensate for the missing kidney, but does compensate to some degree to really account for some of the missing function. And we really select individuals here that have more than enough kidney function, such that the remaining kidney function that the donor will have will be enough to last them their lifetime. And we know that the risks to donors are very, very low. I'll touch upon that on the next slide. They're not zero risk. Any surgery does carry some risk, but the risks to donors generally are very, very low. Now, donation surgery usually requires a hospital stay of about 3 to 5 days, after which point we ask donors to go home and to recover at home. Usually 4 to 6 weeks is the general recommended timeline for recovery, although we have had individuals that have recovered faster, but we do recommend 4 to 6 weeks off work. There are some complications from surgery that are rare, less than 3%, and the complications, fortunately, are treatable. So infection is by far the most common complication, although it doesn't happen that often. An infection of the wound or infection of the bladder often can occur, treated usually with antibiotics. Blood clots, bleeding, and lung collapse are very rare complications that occur less than 1% of the time at our institution. So extraordinarily rare and treatable complications, but rarely are transfusions ever required for bleeding, and very rarely do we require anything in addition to that. There is a slight risk to donors over the long term of developing high blood pressure. We know that the kidney is extraordinarily important in terms of blood pressure control. So there is a slight increase in blood pressure that can occur after donation. And if blood pressure does get to a range where it needs to be treated, donors can utilize the same medications that are used for the general population to treat high blood pressure. We do know now that there is a slight increased risk of developing kidney failure for donors as compared to non-donors. Although that number is higher in donors versus non-donors, it's still incredibly low. So if you look at the actual probability or the likelihood of developing kidney failure, for the vast majority of donors, that risk is far less than 1%, in fact, far less than 0.5%, and still far lower than the general population. So although there's a slightly increase in risk, the increase in risk is very, very minor and still extraordinarily low. And if you put it into context, often this helps people kind of really think about risk, is to put it into context in terms of other activities that are done that are on a day-to-day basis. So for example, the risk of getting kidney failure is likely less than the risk of dying getting into your car driving to work every day in your lifetime. So when we compare risks, that's often a useful way to compare risks in terms of putting the proportion, the percentage into context. And a key component of donation is follow-up care. And often the kidney donors will follow up over the long term with their family physicians to ensure that any sort of issues are caught early in the process post-donation. And we do recommend annual follow-up care for living kidney donors with their family physicians. In terms of psychosocial outcomes, we know that donors experience a lot of psychosocial benefits from donation. It's really quite powerful to be able to help someone in need, effectively save their life. So this really improves generally the health and well-being psychosocially for the donor. Generally, when we look at outcomes psychosocially, the psychosocial health of donors was either unchanged or improved after donation when looked at in a large scale. There are some donors that do experience some psychosocial difficulties after donation, like anxiety, depression, or stress, but the occurrence of that extraordinarily low, and very, very few individuals regret their decision to donate a kidney. And commonly we hear people say they would do it again. Unfortunately, that's biologically not possible, but certainly something that people will tell us after they've donated. So who can be a living kidney donor? And I will preface the next few slides by saying that it's impossible in one presentation to cover every scenario. And so what I'm going to do is try to touch on some of the common scenarios that come up. But again, the evaluation process is really individualized. What we're trying to do is assess the risk to an individual person based on all of their unique characteristics and medical history. And so we do kind of assess everybody individually, and to some degree, every case is a case-by-case basis. But we do have some general guidelines. So let's first start by touching on absolute contraindications. So people who absolutely cannot be living kidney donors. So anybody who is less than 18 years of age, we currently do not accept as living kidney donors in the program. At the present time, anybody who's had a previous history of either coronary artery disease or cerebrovascular disease. So this can include anything like a heart attack in the past, a bypass in the past, needing to have a stent put into the heart, one of the arteries of the heart, or cerebrovascular disease can include anything like a mini stroke or even a stroke. Anybody who has active cancer that is currently being treated cannot be a candidate. We have numerous individuals who have had cancer that has been successfully treated in the past who do go on to be kidney donors. So examples of that is fully treated breast cancer. Several years after, people can donate depending on their individual circumstances, thyroid cancer, for example, and skin cancers that are not melanoma. A lot of people have donated in those circumstances, and we do assess the cancer risk in each individual that comes forward. Anybody who has a history of melanoma, however, cannot donate at this time. We know that melanoma often can come back years after it has presented itself, even though it's been successfully treated, and there's always concern that it can be transmitted to a recipient, and as a result, those with melanoma are excluded. Anybody with an active or untreated infection currently can't donate if infections are treated in the past. So for example, someone with hepatitis C infection that has been successfully treated can go on to donate. So we're looking here at specifically those who have active untreated infections that cannot donate. Anybody who has an active psychiatric condition or substance abuse problem at the present time of their referral can't donate. But again, if those issues have been treated or in the past, those individuals can eventually go on to donate. And the presence of type 1 or type 2 diabetes is a contraindication to donation. How about people who can donate? So if you're overall healthy with no medical conditions, and generally a healthy individual with no medical conditions can donate. Often though, individuals are healthy but have well-controlled medical conditions. So an example of this is high blood pressure. There's lots of individuals that are very, very healthy that have high blood pressure or high cholesterol, for example. Those individuals may be suitable to donate if, for example, they are older than 40 years of age. Generally, that's our cutoff for high blood pressure. And we want to see that high blood pressure has not caused significant damage to the organs in the body, like the heart and the kidney. So that's part of our evaluation process. But if high blood pressure is not associated with any damage to other organs, then generally those individuals, if their blood pressure is controlled on either 1 or 2 medications, can proceed with donation. Obesity is another issue that we encounter in our program, and those with a body mass index of less than 30 kilograms per meter square can donate. Acknowledging that there are some limitations to using body mass index to assess obesity. So we don't, by and large, these are case-by-case assessments for those with BMIs that are elevated, because it's not a perfect mechanism to assess obesity. Those who have a BMI that is higher than 30 are often assessed to determine if they have a low risk profile for kidney disease. So we know that obesity is associated with chronic kidney disease and risk of end-stage kidney disease. So we do want to make sure that individuals do not have high-risk features for getting kidney disease. And that's why these are case-by-case assessments. Diabetes, as I mentioned, is a contraindication. However, there's a lot of individuals that do come forward with abnormal blood sugars that are not completely diagnosed as diabetic. However, they have pre-diabetes, for example. A lot of times those abnormalities can be reversed or changed with certain changes to lifestyle. And in some circumstances, those individuals can be acceptable candidates if the blood sugar is abnormal, but not complete, but doesn't qualify as diabetes. So again, those are assessed on a case-by-case basis. And finally, another common scenario is kidney stones. Individuals who have had an episode of renal colic, or kind of one of those episodes where the kidney stone is quite painful to pass, often we will like to wait about 3 years or so to determine to evaluate for suitability. And that's really because we know that kidney stones are associated with an increased risk of chronic kidney disease. So we do want to ensure that the risk of getting another stone in the kidney that remains is quite low. Now, in some circumstances, donors will be suitable to donate, and in an ideal scenario, that individual will donate directly to their individual that they've identified. But in some scenarios, there can be incompatibilities between the donor and the recipient. So that can be because there's blood group incompatibility or something called HLA or tissue incompatibility. And that just means that an individual can't donate directly to their intended recipient, because if one were to do so, the outcomes would be really suboptimal and the kidney may not be accepted as part of that recipient's body. So what we're looking to do is individuals want to be able to still donate and want the recipient to be able to be transplanted. So the kidney pair donation program is really the solution to that. So the kidney pair donation program is a Canadian program that is operated by Canadian Blood Services. And what it allows individuals to do is to donate a kidney, not necessarily to their intended recipient, but to donate to somebody else in order for the recipient to receive a kidney from somebody else. So this is actually a common scenario, and I'll show you a graphic of how this works. But about 30% of people actually require the kidney pair donation program for their transplants to occur. And it's a very successful program, having allowed over 700 transplants to take place since the inception of the program in 2009. So just to show you a little bit of how the program works, you can imagine, for example, that if this individual here from pair A wants to donate to their recipient, but they're not compatible. Same for pair B, and same for pair C, although they can't donate directly to their intended recipient. Often what will happen is that donor A will be compatible with recipient B, donor B will be compatible with recipient C, and donor C will be compatible with recipient A. So although individuals here are donating directly to their intended recipient, everybody here benefits by getting a transplant by putting these incompatible pairs together in this chain. So this is often what you will see if you're participating in the kidney pair donation program, that you will be part of a chain that can be 2, 3, 4, 5 pairs. There are variable lengths of chains, but this type of program really allows the end result to occur, which is a successful transplant. There's also other types of chains that take place in the kidney pair donation program, and often these chains are triggered by non-directed anonymous donors. So these are strangers who want to, or individuals who want to donate to a stranger just because they are willing and wanting to help someone in need. And these individuals are critical to the success of the kidney pair donation program, because often what they will do is they will trigger a chain of transplants that otherwise wouldn't have been able to occur. So this is an example here where pair A was incompatible and pair B was incompatible. And what happened here is this non-directed donor was compatible with this recipient A. The donor A donated to recipient B, and donor B donated to the list. So what you can see here is, rather than this anonymous donors just donating to an individual on the waiting list directly, they have allowed 3 transplants here to occur by one donation. So it really is a domino effect, triggering numerous transplants by just one individual. So these individuals are really critical for the success of the kidney pair donation program by triggering these domino type of pairs. And lastly, I just want to touch on the last little bit of my presentation is on out-of-country donors. So many people will often ask if they have a donor that lives abroad, if that person can donate to them. And the answer before COVID was yes. What we would typically do for out-of-country donors before the COVID pandemic is that they would conduct preliminary testing in their home country. That preliminary testing would be sent to our institution. We would review it to ensure that it was acceptable. And then those donors would then come to Canada if a visa was granted, and we would write letters of support in order to help donors come to Canada to complete their evaluation, which would be the CT scans and the consultations here at Toronto General Hospital, and then a subsequent transplant would occur if that donor were found to be suitable. The only issue with the out-of-country donors is that depending on the home country of the donor, the success on getting a visa for that donor is variable depending on the country of origin. We unfortunately, as a program, don't have any control over visa granting processes. So we are able to write letters of support, but unfortunately we're not able to grant visas ourselves, of course. Now, since the COVID pandemic has taken place, and we're currently in the middle of it, the out-of-country program is on hold because of the limited travel and the difficulty in getting donors here because of the restrictions. We, of course, are assessing this on a regular basis, and as soon as we are able to return to pre-COVID operations, our program certainly will do so. But at the current time, because of the pandemic, we are on hold. But certainly local donor evaluations continue to take place, and that's both donors that are residing in the Toronto area, in the province of Ontario, and even across the country. So those local programs and provincial and national assessments are ongoing. I just want to end this talk by just summarizing a little bit of what I've said to you today. And so the first thing is I hope that I've been able to share with you why kidney transplantation is the treatment of choice for patients with kidney failure. And between living donation and deceased donation, a living donor kidney transplant is the preferred treatment for individuals with kidney failure. I hope I've been able to share with you that in healthy, well-selected individuals, living kidney donation is safe with very low risks, and and our process is committed to a rigorous evaluation of living kidney donors. And the eligibility for donation is determined after that rigorous evaluation. And what we want to do here is identify the individual risk of a person coming forward in order to ensure that those risks remain low. And so with that, I'm going to stop. I'm going to turn it over to Paula to introduce our next speaker, who has a very kind of valuable perspective as a living donor herself. So Paula, over to you.
Thank you very much, Dr. Singh. That was a very, very comprehensive presentation, and I know there will be lots of questions from the audience. So I invite anyone with questions to submit your questions. Go to slido.com, and the code is kidney donor. That's slido.com, and the code is kidney donor. I'd now like to welcome Jane Garrett, who is a living kidney donor, and she'll be sharing her story. We're very happy to have Jane with us for this seminar, and Jane's recipient, Janet Wright, who you also see in this picture, will be sharing her story in 2 weeks' time when we have another session on kidney donation. So Jane, I'll turn it over to you.
Okay, thank you very much. Thank you for having me. I appreciate the opportunity to share my story. It's not necessarily as much of my story as it's Janet's story, because Janet's the one who benefited the most from this. I'll give you a quick background. Janet and I have known each other since about 1988, which is a long time, which makes me feel very old. And again, as our relationship, we got to know each other very well, became good friends. We've traveled together, we've skied together, we've played together. We've had our kids grow up together. The most amazing thing is how strong she was in her determination to fight her kidney disease, but she has polycystic kidney disease, which, it does catch up with the recipient. And I could see over the last few years the toll it was taking on her and her body. Her life became very small. She ran out of steam. She didn't have the energy anymore. So knowing this over the years gave me the opportunity to think, if she ever came to this point in her life, I would consider, donating. So sure enough, the time came along and Janet needed a kidney. She had a few other candidates ahead of me who did not make the full gambit to do the kidney transplant. But when I started the process, I think it's really important to think down the line of the whole process. So my husband turned to me one day and said, if you're going to start this, you've got to finish this. So I think it's important for the donor to understand everything that they're going to go through and how they're going to come out at the other end. I'm not the only one. I'll just go back on this. I'm not the only one in our family who's donated. My sister-in-law donated a kidney as well, and my nephew donated part of his liver. So we're pretty familiar with the process. And so I had a lot of support because they had both done it prior to, my sister-in-law had donated prior to my activity. I would do it again. I was blessed. I mean, I cannot understand what this gift really means to the recipient. My life, I have surgery, I pack up my little bag, I go home, I recover, and my life continues on pretty much the way it had before. But for the recipient, their life totally changes. They have a life back, which they didn't have before. So I think it's really important. I can't even fathom what that's like, but it's important to pay attention to the fact that this is not just happening to you, this is happening to them, and it's also happening to their families. Janet's pretty stoic. She's a great candidate she was a candidate for getting a kidney, which was fabulous. She was not keen on going on dialysis. She just really wanted to move on with her life. I just had a couple other things. We did consider the KPD program if I was not a match for her, and I would have done that in a heartbeat. A kidney is a kidney, as long as the end result was that she got one that worked for her. The testing was it was very easy to do. As you got closer and closer, it was, the staff at the hospital were amazing. I can't say enough about them. They're spectacular. They're also supportive, physically, mentally, spiritually. I mean, I could not have said enough about them. The only, going in for surgery is never easy. I think about a minute before they took me in, I had a total panic attack. But that's to be expected. And my recovery was very quick. I was out of the hospital within 2 days. I live north of Toronto. I only spent, I think, 2 nights in Toronto, and then I was back home where I wanted to be. And then I just took it easy and slowly worked, getting more energy. I think I lost, I didn't have as much energy for probably 6 months, but that, that's the body adjusting to any surgery, and especially without having the extra kidney to help flush out things. The greatest part of our donation together was our timing of our donation was quite critical, because 10 weeks after the donation, my son got married in the Bahamas. And the best thing was we were both there dancing. So Janet it was so great to see her so full of life again. And I think as a kidney donor or any other organ, it's amazing to see what happens to the other person. It's like a shriveled up flower who all of a sudden blossoms. And I think that's the most important thing as a donor, to remember that your gift is the gift of life. It doesn't matter if it's heart, liver, kidney. It's just spectacular to watch what happens to the other person. I always found, being at Toronto General Hospital, it was just so amazing hearing somebody saying they had a double lung transplant or heart transplant or liver transplant or kidney transplant. And the enthusiasm it's just over the top. So I'm not really sure what else you'd like me to say today, except for my experience has been very positive. Janet's has been over the top. I love her to death, and I'm so thrilled it worked. And I'd be happy to answer any questions that anybody has.
Thank you. Thank you very much, Jane. That was very inspirational, and I know many in our audience do have questions. So a reminder, go to slido.com and enter event code kidney donor. And you can also vote questions up and down. If there are things that you'd like us to address earlier on, please vote those up. We'll hope to address all of the questions that have been submitted. So at this point, if we could show some of those questions on screen, we will review them and invite Jane and Dr. Singh to address them. And while we're waiting for the questions to pop up, Dr. Singh, one of the things that comes up often is folks, have questions about the amount of time that it takes to start the assessment process. Sometimes there's a bit of a mismatch between, when the living donor application is submitted to UHN and when the living donor might be contacted. Would you be able to speak to the process, what happens, in those early stages, and how long a living donor the candidate may need to wait until they're contacted or the assessment process starts?
Sure, great point. So I think the first thing that I want to highlight is that there are two parts to making a transplant happen. There's the donor evaluation part, of course, to make sure that a donor is a suitable donor. But of course, the recipient also needs to be evaluated to determine that they're a suitable candidate. So the way that our program works is that we do begin evaluation of a donor once our program has received a referral for that recipient to be evaluated at our program. Otherwise, we're evaluating a donor without really knowing who that person is donating to, and those are critical pieces of information. So we will first need to receive a referral for the recipient to ensure that that recipient has been exists and that we have them registered in our system. And that recipient will then be seen within our program by one of the transplant nephrologists to determine their suitability. Once they're deemed suitable or eligible for a transplant, we then will begin the donor evaluation. So from the time that a donor evaluation starts to the end of the evaluation process, that that process in itself has decreased in terms of length of time over the past several years. So for someone who is able to attend all of the appointments that we have scheduled for them, we can get through that process in about 2.5 to 3 months. The caveat there is that along the way, sometimes we do find certain medical conditions that require further evaluation. Sometimes there's simple things that can be quickly assessed, but sometimes more complex things are identified. For example, somebody has a CT scan of the abdomen and a lesion on the kidney is identified that potentially looks like kidney cancer. That obviously needs to be evaluated before any donation can take place. And that sometimes can add time to the evaluation process depending on what we find in the evaluation process. However, if we don't find anything of concern, that evaluation time for the donor is usually 2.5 to 3 months. Now, in terms of time to transplantation, in order for a transplant to take place, we need a cleared donor, but also cleared recipient. So the time to get to transplantation really is dependent on 2 individuals, not just the donor. So sometimes depending on what is going on with the recipient in terms of their suitability, there may be variable time points to getting to transplant. But the donor process itself, once the recipient referral has been received, reviewed, and the recipient has been deemed eligible for a transplant, the donor part of the evaluation usually takes about 3 months.
Thank you for that. And Jane, what was the wait like for you? What was that process like for you?
The process was pretty straightforward, but I felt emotionally I actually told Janet that I had to separate her from myself at that stage because it was about me. I had to make sure that I was prepared to go through, and everything that was being done on that side of the equation was about me. It was actually very quick. We were very fortunate because there was a time restraint with my son getting married. I do remember the day that they called me and said that we were a match and that I was able to donate to her. I picked up the phone and I told her, and she was just over the moon. It was probably the best day of my life.
Yeah. And it is important to remember that there are separate teams that assess the recipient and the donor, and that communication is also directed. So the recipient team will communicate with the recipient, and the donor team will communicate with the donor. Dr. Singh, sometimes that can be a bit confusing for folks.
Yeah, that's a good point. So one of the reasons that we do separate the teams is that, for example, myself being part of the donor team, my priority is to donor evaluation, the safety of the donor. And we separate our teams so we are completely unbiased and that we are only focused on our respective roles. And for me, my priority is donor safety and the donor evaluation. We do have to recognize that although there is a linkage of a donor and recipient, there are 2 individuals with their own private health information. And we have to respect that health information can only be disclosed to that individual. So for example, I would only be disclosing health information to that donor, whereas that information, of course, is relevant to whether or not the recipient is going to be able to receive their donation, their donor transplant. We have to really respect the privacy of the individuals involved. And that's why we do encourage the donors to share with the recipients at their own with their own comfort level in doing so. But a lot of people want to go through, donors want to go through the whole process, and they don't want to share any information with the recipient until they're completely cleared and they're completely sure that this is something that they want to do. And that's a process that we completely respect. Every individual is different, but the privacy of the information is critical. And although information certainly from one side affects the other and vice versa, we are committed to keeping the separate teams in order to make sure that everybody's privacy is protected.
Thank you. We now have some questions. Sure.
Can I just add that? When we went through this process, Janet had 2 candidates before we tried for myself. And the psychological aspect when they weren't a match on her was devastating, because her hopes, they get their hopes so high. And so when we were a match, it was great, because I just could not imagine telling her that we weren't. It would have been very difficult.
Yes,
Sorry.
It's a difficult time, I think, for the recipient and certainly for the donor as well, because often, there are things that you find out about your own through medical assessment, through health assessment, that may be surprises for some, and can also require a bit of time to process. So I'm looking at some of the questions that we've received, and maybe we can go through these questions. And I guess this first question is for you, Dr. Singh. Are there restrictions in place for the LGBTQ community?
Yeah, good question. So there are no restrictions in place. Every donor candidate that comes forward goes through the exact same evaluation process that I described in my talk. So no, there are no restrictions, and we certainly invite everybody who's interested in donating to self-refer, and the evaluation is the same for all individuals.
Thank you. This next question is also pretty important. At what stage should the process be started for a potential donor? So when should the recipient begin thinking about a living donor?
Good question. So the ideal timing, and ideally we would like individuals to be able to be transplanted preemptively. So Jane described exactly that situation where a transplant was available for her recipient before her recipient required dialysis. So the best time actually to be starting to think about finding a living donor is long before one even is approaching the dialysis unit, and hopefully they never get there. What we're really trying to emphasize in multidisciplinary care clinics or chronic kidney disease clinics is that is the time early on in the stage of developing kidney disease, especially if things are progressing, that a donor is identified. So that really, the earlier a donor is identified, then the more chances of a successful preemptive kidney transplant. Of course, if somebody's on dialysis, it doesn't mean not to seek out a donor at that time, because certainly time on dialysis can be substantially shortened. But the earlier in the process that one can identify potential candidates, the better. And that's something that individuals who are living with chronic kidney disease should be speaking about with their current nephrologist, and something that we are certainly encouraging nephrologists to do in chronic kidney disease clinics, or MCKC clinics also called, to discuss living donation as the preferred and first treatment option for kidney failure.
Thank you for that. And a reminder to our audience that the center offers webinars every Tuesday for kidney recipients or donor candidates who are considering or exploring living donation. These you may register on Eventbrite, and these are available to anyone, whether they've been referred to UHN yet or not. So if you are interested, I would encourage you to register for one of those sessions. So the next question is very timely. It relates to COVID. What impact has COVID had on the assessment process, on the evaluation and qualifying to donate?
Yeah, that's a great question. So initially when COVID first started and the first kind of lockdown or stay-at-home order was put in place back in early 2020, as you can imagine, we really didn't know what this virus was all about. And the Living Donor Program at that time did briefly shut down for a few months. And that was really in order for the hospital to be able to redeploy individuals to focus on COVID-related activities. Now, since that shut down, we are now back fully operational. So back at the time when the program was shut down, there were obviously impacts on the donation evaluation process. The program was closed, and so evaluations were not taking place during that shutdown. Since then, we have been now back fully operational, and even despite being in the second wave, we now know a lot more now than we did back then. So we're continuing to go through evaluations, and really generally we're able to keep up with our previous kind of pace of activity in this second wave. So initially there were some effects on the donor program, but I would say now we're effectively back to our regular operational procedures in the donor program, despite the second wave and even potentially a third wave that may appear.
Mm-hmm. Thank you. And there's also testing for donors, COVID testing, et cetera.
Yes, we do add a few. There has been the additional step of COVID testing before donation can take place. So that is true. Thanks, Paula, for bringing that up. So there's additional steps that do take place as part of the evaluation process before donation to, of course, make sure that individuals coming to the hospital are free of COVID symptoms and individuals donating are free of COVID disease.
Mm-hmm. Thank you. Our next question is, I guess this is a question that comes up often. Does a kidney donor need to be on medication to compensate for having one less kidney? Could you speak to living kidney donation to pediatric patients, because we also work very closely with sick kids?
Sure. Yeah, I'll take the second question first. So we do have a very close partnership with Sick Kids Hospitals and our Sick Kid Hospitals, and our donor program does evaluate donors for pediatric recipients. And we have terrific surgeons. An adult kidney can successfully be transplanted into a pediatric recipient, despite their small size. We do this all the time, and it's a very successful procedure. So yes, it can be done. In terms of health after donation. So a kidney donor does not need to be on medication for the rest of their life as compared to before, based on donation alone. So naturally, of course, if somebody was taking a medication for another reason, so for example, high cholesterol tablets were being taken by a person before donation, that medication naturally would continue after donation. But just because of donation itself, that doesn't cause an individual to be on medication for the rest of their life. Donors often go back to living kind of completely normal and healthy lives. And the kidneys are really quite amazing. The body does adapt to having one kidney. It grows and kind of filters extra blood for that missing kidney and does really adapt quite well. So overall, really, medications should not change. And also, I should also mention that it doesn't change your ability to receive, for example, general vaccinations like the flu vaccine or the COVID vaccine. Really, the general population recommendations continue to apply to living kidney donors after donation. The only thing I will say is that anti-inflammatory medications are generally not recommended after donation. So that is the one thing that you cannot take, or that we recommend that you do not take on a regular basis. So this is not so much about medications that you would take, but it's more medications that you would avoid. And that's because these type of medications can decrease blood flow to the kidney and can cause injury to the kidney. So we do recommend avoiding those in terms of chronic use after the donation surgery.
Thank you. This next question really relates to the decision around living donation. So Jane, do you feel that you received enough education and information to make a decision?
I felt like the process was very good, and I had the right information. The staff were fabulous with any questions that you had. You could call if you had a question for the support. I'm going to say yes, totally, 100%.
Mm-hmm. Thank you. And I guess, the important thing to emphasize is that living donation, the process proceeds at the speed of the donor candidate. So at every step along the way, the donor may decide that this is not for them, that they need more information, that they would like to take the time to consider the information that they've been provided, and that's okay. The important thing is that it be a voluntary decision, an informed decision, and the donor candidate is encouraged to take as much time as they need in order to feel like that decision is right for them.
Right.
These next two questions, I guess, are really for Dr. Singh. Dr. Singh, could you speak to the potential for a living kidney donor to sort of have repercussions for the remaining kidney? And are there other risks that really we need to be considering in the assessment process?
Okay, so I'm just, so I'm going to touch on the first one here, the potential of overload function. I'm not sure I totally understand the question, but I'm going to speak to this topic and I hope I can answer what this individual is asking. So, the kidneys are quite remarkable. When one kidney is removed, the other kidney really adapts by growing and filtering more blood to compensate for the one that's missing. So in fact, although mathematically, you would expect that your kidney function would go from 100% to 50% because you lose one of your two kidneys. The other kidney adapts and can compensate and really make up for some of that kidney function that is missing to about 65 to 70% of the original kidney function. So although you can't completely compensate for the kidney that's missing, the kidney is quite remarkable that it can compensate to get the individual back to 65 to 70% of their original kidney function. Now, as I mentioned, we're not selecting individuals with borderline or marginal kidney function to start with. We're selecting individuals with an abundance of kidney function in order to permit a kidney to be donated. And as many on the call many on the webinar may know, we are all born with a little bit more kidney function than we need, but not everybody has the same degree of kidney function as a starting point. So we're selecting individuals through our evaluation process who can accommodate kind of this loss of function. There's really no kind of risk of overload function per se. Most people will end up somewhere between 65 and 70% of their original function. Kidney donation in itself doesn't cause kidney failure, but sometimes other things can come into play that can affect the kidney that remains. So for example, if somebody develops diabetes after donation, that diabetes is untreated, it can cause some changes that really stress that remaining kidney. And so that may kind of create additional stress on the kidney depending on how well the condition is treated. But donation in itself doesn't, quote unquote, overload the kidney that remains. So I hope that answers that question. We talked a little bit, I'm going to address the second question in just a minute. I just want to touch on the restrictions for a donor in terms of age. So I mentioned the lower age limit of 18 years of age in terms of donation candidacy. We do not have an upper age limit. The oldest donor that we have had in our program, I believe, was 75 or 76. I can't remember exactly the age, but we do have lots of donors in their 60s and 70s that are very healthy that go on to donate a kidney. So age in itself is not a disqualifier. That being said, we have had individuals in their 80s come forward, and overall we have to look at the collective health, and often there's numerous changes in the kidney that can happen with aging, especially in one's 80s. There can be a fair degree of scarring in the kidney that, although is not a problem for the donor, may not be enough function for a recipient to receive. So although we don't have an upper age limit, practically speaking, we have been clearing donors up into their mid-70s, but we have not gone beyond that. But lots of donors in their 60s who are very healthy have gone on to donate successfully at our program. I also wanted to just touch on the next question. Does the clinic assess one potential donor at a time, or can a patient provide multiple names for potential donors and have them all assessed at the same time? So this is a really important point. So if, let's say, an individual has multiple donors that are willing to donate, it's really important for all of those donors, if possible, to submit their questionnaires around the same time, because what we would then do is identify the best candidates in terms of donation, in terms of blood group compatibility, as well as medical conditions that would make a donor kind of more favorable. So we're looking to choose the lowest risk individuals to donate, and also, where possible, have a direct donation occur. So, so often blood group will play a decision in that, play a role in that decision. We do evaluate one donor at a time, and that's really to ensure that we can be equitable in terms of access to the resources for all individuals who have potential donors in the process. We have fortunately been able to improve the time for evaluation. So if somebody is not found to be suitable, they often are told that quite early on in the process, such that we can move on to another donor quite rapidly thereafter. So generally, we do follow in terms of ensuring that the process is equitable. One donor is evaluated at a time for one recipient, but we do try to make those decisions as quickly as possible so we can move on to the next donor if the first candidate is deemed unsuitable.
Mhm. Thank you very much, Dr. Singh. We've reached the end of our time, but we have more sessions coming up. I would like to invite everyone who's interested in living kidney donation to join us in 2 weeks' time, when Dr. Pei will be talking about polycystic kidney disease. And there will be, and you will also be able to hear Janet talk about her living kidney recipient story. And finally, Dr. Singh will be back with us on April 1st in a presentation on diabetes. So please join us for those sessions. There are other sessions that the center is also hosting. Visit us on Eventbrite. I'd like to thank our 2 speakers today, and thank you for joining us, for your questions, for your interest, and we look forward to seeing you at our next session. Thank you very much.